Good morning. Well, that was a fascinating presentation. This presentation is showing how the old technology failed and the new technology rescued my patient. Only thing to disclose on my part, nothing to do with money, but I was trained in city surgery at MUSC long before some of you are born. So I won't admit to my age, but anyhow, you see my co-author is Dr. Minion. He will get all the credit. We do cases together, including this one. But this case began with me when Minion was still a student. And this gentleman is 75 years old who had a recurrent rest pain. I'll give you a little bit of past surgical history. 21 years ago, he presented a non-healing ulcer of the first toe of the right foot and underwent outer bifemoral bypass. That was the standard of those days. Later on, that graft got occluded, and we had to redo the outer bifemoral bypass. The new technology has not arrived yet. He came back again. The graft was occluded. We didn't want to go back to the belly, wound up doing a axillobifemoral bypass. Surprisingly, that lasted for 13 years. So this time, the recurrent rest pain, you see the new pre-op CTA. So you see there's an accessory renal on the left, fairly good size, and see the clots right between accessory and the main left renal artery, and obviously the bifurcation is occluded, and a severe calcific disease with thrombus in the lumen. So I called up David. I said, David, this is a tough one. Let's work together. So we did. So I started this angioplasty, crossed the occlusion, and reconfirmed the entry, dilated with 5mm balloon. And you can see the marking of the angiography, and 2 catheters that have gone up. And here you see some stenosis coming from the arm, cannulated the accessory, and then we put the valve and graft that came up from both sides, and also had one in the renal artery. Deployed the stent. We used the balloon to protect. We did not put a balloon on the right. We talked about it. We should have done that because we should be concerned about the embolization. But most of the clot was on the left side. You can see the post-stent dilatation and see the angiography. You can see the arteries have been opened up. And so at the bifurcation on both sides, we had an issue, so we had to extend that to cover that area. There's a right limb extension, protect the internal. And here's your postoperative. You see all those graft. There's a post-CTA, and here is your 3D reconstruct. This patient is very happy and satisfied, and before he left home, he left on the same day, he said, Dr. Saha, your student is really smart. Every time you did operation, I stayed in the hospital for days. I can go home, and my leg feels better. I said, well, he's not my student. Well, he's very young. He looks like you're a student. I said, okay. But the patient remained loyal to that. And I have quite a few of those, but it's interesting what you can do with your new technology. And of course, you see his ABI has been restored to normal. He has not quit smoking. He said, I'm trying. He's a classic Kentucky patient. We call Kentucky uglies. They have hyperlipidemia, smoking, hypertension, type 2 diabetes, all mixture. So you got some of this stuff under control with medication, but cigarette, he said, well, think about it. I've cut down from 3 packs to a pack in 27 years. That's an improvement. I say, absolutely. Let's keep coming back. Thank you for your attention.